Hello there. In this 10-minute medicine talk, I'm going to cover the assessment and management of a patient with hypernatremia. So what is hypernatremia? This will depend on the reference range used by your local hospital. In most cases, this will be a sodium of more than 145 millimoles per litre. This can be picked up incidentally in a substantial number of cases on routine bloods. However, it can present symptomatically with non-specific features, such as lethargy, thirst, irritability, weakness, drowsiness, confusion, seizures, or coma. So what are the causes of hypernatremia? The most common cause is unreplaced water loss. These can be losses from the gastrointestinal tract, from sweat or pyrexia, through the skin from burns, renal losses through the use of osmotic diuresis, glycosuria, such as in diabetes, or reduced ADH release or action, such as in patients with diabetes insipidus. Inadequate intake of fluid can be a cause of patients with hypernatremia. This is more a feature in elderly patients or patients with hypothalamic disease who may have an impaired thirst response. A less common cause of hypernatremia is excessive sodium. This can be iatrogenic through use of excessive saline infusions or primary hyperaldosteronism, typically associated with raised blood pressure, low potassium, and alkalosis. Assessing a patient's volume status is important to determine the appropriate management for a patient with hypernatremia. Features that may indicate a patient is hypovolemic include tachycardia, postural hypotension, dry mucous membranes, reduced skin turgor, confusion or drowsiness, and a reduced urine output. Conversely, a patient who is hypervolemic may present with a raised JVP, features of pulmonary edema such as bibasal crepitations on chest auscultation, or signs of peripheral edema. Investigations for hypernatremia usually include blood tests to exclude other causes for hypernatremia. These include serum glucose to exclude diabetes mellitus, serum potassium to exclude hypokalemia as a cause of nephrogenic diabetes insipidus, serum calcium to exclude hypercalcemia as a cause of nephrogenic diabetes insipidus, and plasma osmolality. Urine osmolality is also important to help determine the underlying cause. There are also further investigations that can be performed if diabetes insipidus is suspected. These include a water deprivation test, a CT or MRI of the head if there's a suspected cranial cause of diabetes insipidus, and also reviewing medications because lithium and dimethylcycline can both cause nephrogenic diabetes insipidus. So how do you manage a patient with hypernatremia? As I said before, volume status will determine the management. If a patient is hypovolemic, you have to replace their circulating volume using 0.9% sodium chloride, usually with 1 litre every 6 hours. Although this is counterintuitive, in a patient who is hypernatremic, 0.9% saline is actually relatively hypotonic. and you will continue infusions of 0.9% sodium chloride until a patient is normovolemic. In a patient who is normovolemic and hypernatremic, you can either encourage the patient to have oral fluids, or if they are unable to do so, you can give them 5% glucose infusions with 1 litre over 6 hours. It's important to continue to monitor the patient's fluid balance and plasma sodium, and to help with this, consider inserting a urinary catheter. We should aim for no more than a decrease of 10 millimoles per litre in the 24-hour period. It is also important to address the underlying cause for a patient's hypernatremia. If diabetes insipidus is suspected, it is useful to seek advice from endocrinology regarding whether further investigations are warranted and appropriate management for these patients. Desmopressin is often recommended for patients with cranial diabetes insipidus, whereas drugs such as benzoylumethiazide or NSAIDs are used for nephrogenic diabetes insipidus. As I was alluding to earlier, urine osmolality is extremely useful in determining what the underlying cause of hypernatremia could be. If urine output is low and urine osmolality is high, typically more than 800, then an extrarenal water loss or reduced intake of fluid is likely to be the underlying cause. If urine output is high, but urine osmolality is low, then diabetes insipidus is likely. Cranial causes can be idiopathic, congenital, or due to an underlying CNS pathology. And cranial diabetes insipidus is diagnosed by failure to concentrate urine with both water deprivation, but the urine does concentrate after administering desmopressin. In the patient with nephrogenic diabetes insipidus, these can be caused by drugs, as alluded to earlier, electrolyte abnormalities, as previously mentioned, chronic kidney disease, post-obstructive uropathy, and congenital causes. In patients with nephrogenic diabetes insipidus, they will fail to concentrate urine with both a water deprivation test and desmopressin administration. If urine output is high and urine osmolality is also high, then suspect osmotic diuresis, such as patients with diabetes mellitus who have excessive glucose in their urine. Thank you for listening.